Okay, no problem. So this slide is just an attribution. Our funding comes from CDC, so our component 2 project is funded directly from them. So you can flip on to the next slide. And I thought I'd just go over real quickly the aims of this component 2 project. So we have 3 aims that are a part of this project in the development of that arthritis care model. And we're partnering with a few partners to do this work. So the first aim is that evidence-informed arthritis care model, to develop that evidence-informed approach that I talked about earlier. And then the second aim, we take that model and we're going to demonstrate it through a pilot project. So we're kind of moving into the aim 2 work right now, and then aim 3 is scale and spread. So we hope to get here. We hope that the pilot will be successful. We hope that we'll learn and then be able to tweak and scale and spread our efforts in future years. So next slide. This is kind of the timeline I just went through. We finished up year 1. We're currently finishing year 2. Year 1 was all about a landscape assessment. We looked at the data that was out there. We worked with our partner, Levitt Partners, to do an environmental scan and some interviews. And year 2 was all around this expert advisory panel and working with them to develop our draft arthritis care model, as well as working with our partners in evaluation, which is Dartmouth, and they helped us design an evaluation framework. So right now we're in the process of soliciting applications for pilot sites, of which I think Iowa is going to be one, which we're excited about. And then we will go through some interviews and determine a pilot for our year 3 project. So next slide is just a pictorial of the arthritis care model design partners. And I'm really excited to say that Dr. Welk is one of those partners. So, and Trina's joined some of those calls too. So we're glad to have Iowa represented here. It was a great team of folks. Our last meeting was on September the 12th, and we hope to continue with a smaller group of experts to help us through the pilot phase in our year 3. So next slide. I'll just walk through real quick. You can click, I think. We did 3 sessions that covered the human-centered design. Well, we went through a human-centered design process and used 3 sessions to do that. Levitt Partners helped guide us through this work. Again, Dr. Welk was part of this process. So at any time, Dr. Welk, if you want to chime in, feel free.
Yeah, you're doing great.
But, thanks. So we went through these 3 different sessions to really think about the patient-centered perspective. So we gathered our experts in a kickoff meeting in November, and then moved in to our session 1 in January. Session 2 was in February. Session 3 was in March, and really wanted to hear that patient voice. So we included patients in this process too. So on the next slide, I think is the summary of, so this is our outcome from those human-centered design sessions. So we came out with 8 different outcomes that we wanted our design team to look at as they develop this arthritis care model. And this is just kind of a pictorial of those 8. I won't go through all 8 of them, but you can kind of get a sense for what the outcome of those human-centered design sessions were. So then those design sessions started in May. We took a little break in April to kind of gather our thoughts and come up with a plan for these design sessions. And I probably should have mentioned when I introduced myself that I'm not just a team of one. I'm one person on the team, and we are led by Shalu Garcha. She really oversees this component 2 work. And Lisa Irk is my colleague to work in the component 1 space, but she also provides support, like I do, to the component 2 project. So Shalu couldn't be here today, and either could Lisa, so you got me. So the design sessions that we went through covered a gamut of things, really looking at that screening, counseling, referral, care coordination, reimbursement, and then evaluation. Our last 2 sessions that we had on the 8th of August and the 12th of September looked at the overall design of the health system pilot and where we wanted to go with that, and then how our evaluation framework fit into that piece. So the next slide, I think, is really what Trina wanted to highlight. through this meeting. This is the care model that we came up with. So really the outcome of all the work that we did over the past year resulted in this care model. And this is our first iteration, actually second iteration. And we're in the process of incorporating comments from our September meeting to get the third iteration of this care model. So there's been some updates, but I don't have the graphic depiction yet to share with you. So I'll just kind of walk through what we did. And this is where I think Trina and Greg, you were part of that conversation.
Yep.
So if there's anything that I missed, please chime in. But what this is our care model really sits within the primary care setting and the community hub, and they're connected. And we're trying to show that through this this pictorial where you see the PT, the CHW health coach, and the specialty care. So specialty care will also be connected and bi-directional. But in the primary care setting, we envision a patient coming in. So this is a patient with pain of the knee or hip. They may already be diagnosed with osteoarthritis, or they may not be quite diagnosed yet. So they come into the primary care setting to see their healthcare provider. And through that initial contact, they're probably filling out some forms like a physical activity vital sign, or they're being assessed for physical activity through the physical activity vital sign. They may go through screenings using the PROMIS tool. So there's a function and a pain interference PROMIS tool that they may be screened with, and there may be other tools that the primary care provider screens them with. After that screening, the primary care provider is probably going to provide some sort of brief advice. So that's our recommendation. There's brief advice happening within the primary care setting. There may be some risk assessment being done. The patient is being assessed for readiness of change, and then they may be given a prescription. It may be to exercise, it may be to go and see a physical therapist or a specialist, and then that patient is referred out. So the referral can happen in a couple of different ways. It can happen through their primary care provider. It can happen through a community health worker or health coach that sits within the primary care setting. It can happen directly to physical therapy, or it may be a specialist like a rheumatologist or some other healthcare provider that the patient needs to see. So we tried to depict with this graphic that the CHW may sit within the health coach may sit within the primary care setting, but it also may sit within that community hub. And so the community hub is a really big piece of this arthritis care model, and we see it being important. And in our pilot site, we're really looking for that community hub to be that big piece of this arthritis care model. So I'll pause there for a minute. Trina or Dr. Welk, is there anything you want to add?
I think that was really good.
Yeah, nothing yet. So I'll be sharing, Heather, a couple updates on our projects, and so it'll be evident to the group here that how we're operationalizing some of these within the hub and the outreach to the community-based organizations. So,
okay. I guess I would say, Heather, I was happily surprised to hear from the specialty care providers that they would like the direct connection as well to the hub. And so I know there's, some iterations going on and kind of some modifications there, but as a physical therapist myself, but then also, just with representing the community hub side, I thought that was really great too, is just them wanting that engagement with the hub as well.
I guess I did have one thought, Heather, that's really interesting. The most impactful component to me of this process, I feel really great when we landed on this kind of model, because it's what Trina has been building, but the human-centered design piece was really impactful, that of how it engaged what the perspectives of the patient in different contexts, and also the providers, and so how to reduce the burden. So I'd love to eventually build some of those strategies into our work here. So I have all kinds of notes. They just haven't been assimilated yet and shared in this because it was so much, but the human-centered design piece is really important to make sure we're understanding the needs of the patient. And so you'll hear later, if you stay on the call, about our equity, or ideas of having another subcommittee to kind of help us understand that within the hub. So
yeah, and I think one of the things that came out too of our expert panel design meeting is the need to do some of these screenings. So the screening for the social determinants of health doesn't really happen necessarily within the primary care setting. And I think the overwhelming response from the providers that were a part of our expert committee, and I think you saw we had rheumatologists, we had orthopedic surgeons, we had primary care docs, we had sports medicine docs. So they all, I mean, there's just not enough time in the day when you go to a primary care doc and you have a visit. So having a community hub to do that social determinant of health screening is very important.
Yeah.
So we talked about that. We talked about the need for patient navigators, which also tends to happen within the community hub. So that may be a health coach, it may be a community health worker, it may be a specific navigator that the hub hires to help patients through the journey. They're there to really help determine what evidence-based intervention that patient needs, help coach them through that process. So it may be calling them weekly, it may be reaching out to them on a daily basis, but they help them through their journey. They make sure that they attend those sessions. And you can see this all on the wheel, the green wheel, but attend the sessions, and then they track that information. So they track the attendance and the completion of the evidence-based intervention, and then they share that information back with the primary care doc or the physical therapist or the specialist, whoever it is. So the community hub is a really important piece. And I think that's kind of what Iowa has done. I think you have that community hub model there, and you are working with the community healthcare providers to be able to talk back and forth and provide that information about the patient's journey, which is great.
Yep, that is exactly what we're developing. All right, next slide.
Yeah, I don't know if you want to share this or not, but I threw these slides in there just to let the group know about the journey that we're taking. So we currently have a solicitation out for individuals, and we really targeted the CDC funded arthritis programs, those state arthritis programs, and the Administration on Community Living grantee recipients. They use that NCOA ACL hub model, which is really the model that we've been looking at. And I think that's the model that Iowa uses too. So we have a solicitation out right now. We had an informational session on the 14th of September. We're asking any entity that's interested in applying to be a pilot site to submit an application by the 13th. And these are real informal applications. We're hoping to have some conversations with entities that are interested in piloting this arthritis care model by the 31st of October. It's an ambitious timeline since we have a national grantee meeting we're planning to, but hopefully by the end of October, 1st of November, we'll have those informational interviews. And then hopefully by the middle of November, we'll have a pilot site selected and start the process to get memorandums of understanding, contracts, whatever's needed in place. So on the next slide, and I don't know if you want to share any of this other stuff. These are just the eligibility criteria that we outlined in the application process. So you can kind of read through these, but really it's that AAEBI, arthritis appropriate evidence-based intervention capacity. So these are programs like Walk with Ease, Tai Chi for arthritis, Tai Chi Quan moving for better balance, enhanced fitness. There's a bunch of them out there.
And this is great, Heather, because, you know, this will, Dr. Welk will kind of share just after this, and hopefully everybody here will start to see how we're aligning with, you know, these criteria, and really what it is national best practices and standards. So we're doing our best to align with those, and have already built out some of this, but obviously we want to continue to improve upon those things.
Yeah, that's great. So we also have some health system criteria. So that was the entity criteria, and this is the health system. So we're really looking for an entity in the state that can partner with a health system to implement this pilot project. So these are the things that we're looking for. We know they might not all be in place. We're hoping that there's a few entities that have these types of agreements and relationships with health systems that we can go to for our pilot site.
Yes.
So, and I think that's it.
And I think I just to let everybody know that we do intend on applying So wanted to make sure I mentioned that to the group. And if there's any other health center partners, health system partners that are interested as well, you know, we work with FQHCs on a lot of different projects, but we also have a lot of other partners, even on this call, that we'd love to engage in some of this work. So if they're interested, they can contact myself. So thank you, Heather. Does anybody have any questions at all about this work going on nationally? All right. Well, thank you again. This is, I think, really important work, and we're really happy to be involved as much as we are with this arthritis work, not only with our CDC arthritis grants, Greg on some of those committees, myself, and really trying to align with that work. So thank you, Heather, for always your support and NACDD support. All right. Greg, are you up for the next?
Yeah, sure. So yeah, what we want to do at these periodic hub advisory calls is also provide updates on the ongoing work that we have. So we do have 2 CDC funded projects, and they both harmonize with each other and also with this new opportunity that Heather was just describing. So this is a program project grant funded by the CDC for fall prevention. So we're evaluating the potential of Walk With Ease to be an evidence-based fall prevention program. So it's run as a formal clinical trial. I think we've shared this multiple times, but I'll walk you through a couple slides and we'll focus on updates. So we'll say like where we're at right now, and then 2 months from now, we'll be in a new place. And we'll always try to bring new updates and status reports and things like that. So this will be an update for, you know, basically our year 1 update. So next slide. So the overview of the trial is really that we have 3 aims: process evaluation of the overall implementation of Walk With Ease, how we've done it in a community-based setting. Aim 2 is an outcome evaluation of the trial, and we are comparing, it's a 2x2 factorial design, so we're comparing different exercise regimens and different behavior treatments, and I'll explain that. But the third aim is really a feasibility study of dissemination. So this is exploring the barriers and facilitators of how we would implement this and go to scale. And we're already taking some of those steps by offering training through the organizations that affiliate through the hub, and we can offer free Walk With Ease training through the Arthritis Foundation and supplemental training on, you know, the logistics of really how to do it in practice. So you can click one more, two clicks. So this is the system you've seen before of how we're operating as a translational system with the hub. So you can keep going. And this is our kind of referral model of how we're working with the hub to facilitate enrollment into our trial, and then delivering the program and then feeding the data back to the hub. And that's part of this bidirectional feedback that we've been working towards. So it's really piloting this clinical community model. And, you know, so our project is done at the local level in Story County, and we could enroll our own people and advertise and do that, but we're taking the step to actually work directly through the hub on handling all aspects of the referral process so that we can prepare ourselves for that broader dissemination. And that's what I'll share an update on here. So one more slide. So you've all seen this picture before, but I always go back to it. But this depicts how we're trying to use clinical referrals, and this could be an organization referral as well. So it's not a clinician, it could be a PT, it could be an organization leader or a self-referral, but referrals come into the hub, and then that referral comes back to us as a community-based organization. And so that's what I'll be sharing with you now, how that process has worked in this one direction. So you can click the next slide. And so our project is on schedule. We've completed year 1, and Walk With Ease is running in 2 locations in Ames and Story County. We're hoping to expand that even within our county, because we've had a lot of people that would like us to offer it in other towns in Story County. So as part of our year 1 evaluation, what we wrote in our grant and we followed through is we're evaluating our process every year, and that helps us refine our implementation. So that's part of AIM 1 is a process evaluation. And so we already completed that and shared it with our CDC leadership team. And we're working on our outcome evaluation of year 1, and we've only enrolled about 20 participants, so it's a really small sample. So we're not analyzing the data per se, but we're testing our measurement protocols, and this is all standard practice for running a trial. And we actually have our summary meeting with the CDC on this Thursday to share our annual year 1 report. So the other bullet point there is really about the coordination through the hub, and that's working really well. We've tightened up our process through Smartsheet, and there's really good communication between the hub navigators and our new project manager on coordination. And the other key update really is that we've finished an IRB modification that allows us data sharing to go back to the hub. And this may seem like it's an easy thing, but it's actually somewhat complicated in a clinical trial, because when a person consents, they are consenting to enroll in the study. And for a while, I did not have permission to share information back to the hub about their enrollment or completion status, because the hub was not on our IRB as a research member. But we've worked through a data sharing agreement that does now allow us to share the data back. And so that enables this reciprocal feedback on enrollment. So you can click the next slide, Trina. And so this is really where we've now positioned ourselves, that the Walk with Ease program leader can now send data back to the hub. The hub can then inform the clinicians of that their referrals are getting acted on. And that's really one thing we've heard through that arthritis expert panel, is the doctors want to know, did people enroll and did they complete the program? So again, this is only, it's a lot more complicated for me on our end, because we're running a clinical trial. This type of data sharing agreement is a lot easier with other community-based organizations, because Trina can facilitate a BA/SA agreement with an organization, and that's part of onboarding into the hub. And so that would just become standard practice. So we're kind of paving the way for this referral system to work through the hub. So we're excited to take that step. So, right, next slide. So now we'll share a little bit about the other CDC project. And this is a component A project. So Heather, it's similar to your component 1, 2, 3, but this is a component A. So we're a relatively new state that has adopted this. So we have a lot of pieces already in place, and that's because Trina has been working to build this over time, and I've joined the effort over time, and we've been part of the peer sharing with many of the other states. And I think that's positioned us really to get off to a good start on this project. So I think that slide there just refers to outcome measure 1 is one of our 3 strategies. I think I moved that bullet to another place on my presentation, but our goal is to increase the availability of ABIs through sustainable strategies across 5 years. And that's just one of our 3 outcome measures, but you can keep going, Trina. So this is the main thing I wanted to share. And I think we've discussed this on previous calls, but this is our kind of partner integration model. And we have these 4 teams. Actually, we've formed 6 teams now, but the 4 on the outside are the key cogs in really driving this initiative forward. And we've had meetings with each of these 4 teams, or close. We might have one more team left. So there's referral sources, connector partners, delivery organizations, and ABI coordination. And collectively, there's action items that we've operationalized for each of these teams. Then we also have an evaluation team that our U-Turn group would be managing, and then a marketing team. So we think it's going to be really important to have a strong marketing presence across the state, both to providers, organizations, individuals, and that would include social marketing and some of these human-centered design ideas. There's some really creative ideas about how we can reach individuals that are at risk and help them feel like they really need to take action. And also, how do we make it easier for clinicians to take action? So yeah, any further thoughts on the partner teams, Trina, or updates? We're only 1 meeting away, right, from, I think.
Actually, we actually have
2.
3 meetings still to go.
3 meetings left.
Yep, so we've had 3 meetings, and now we have still the delivery organizations, the connector partners, and the marketing team.
Okay. So I leaped ahead. It feels like my calendar's full every day. So somehow we're running out of meetings. So, okay. So you've also seen this logic model, and this is where I was going to show you that I think we don't have to click through it, or I guess I did click the animated one. So just click through, Trina, because I think the board has seen this. But we're really going to focus and use this model. So the point of a logic model is it does provide the logic. And so we do have performance measures, and these lead to our outcome measures and help us keep track of our progress. So I was just cueing you that, again, the advisory board or Hub Advisory has seen this, and we're working with each of these partners to build that capacity to move these things forward. So my update is on the next slide, I believe. So our status report is really that the project's off to a good start. We've hired new staff. So I have a new project manager that's working with me, and she's doing a great job and helping to connect. And Dawn Dunnigan is also has been connected to, as an extension leader, and she's maybe even joining this call. I forgot if she's on there, but Dawn's been really great getting started, helping us take advantage of what extension really does of spreading evidence-based programs across the state. So we have initiated these team meetings and built our plan for coordinating the project over time. And our kickoff meeting with the CDC is on Tuesday. So we have that meeting as well, where we'll share this progress. I guess I outlined key needs here because this is where we want to really take advantage of all your help. So this is a short list. There's probably many things we need to be doing, but one key need is to capture the scope and reach of current abbeys across the state, and we're going to take action on that in multiple ways, either with landscape analysis or with also just mapping them back to the hub and really tightening up how we know where these abbeys are available and how do we spread that. Second goal, again, is promoting awareness and visibility. So we would welcome any and all of your help to let people know about this project. And maybe to do that, we need to give you flyers or handouts or connect on our newsletters. And so our team will start working with ways to share that out. So maybe Trina, in our update from this call, maybe you can add a flyer and help people forward this on, just so people are aware that this is a great place to address arthritis issues in the state. Then we're also going to ramp up our availability of abbeys, and the self-directed Walk with Ease is probably our first and most prominent target because we can distribute that at scale and virtually. So we can offer, we've already been doing this, and we just need any and all referrals to come into the hub to enable people all over the state to take action through the Walk with Ease self-directed program. We're also working on screening and referral process. So just earlier this week, I presented at the Falls Risk Symposium about our fall risk screening. And that's just one step of how we're trying to work and build screening practices into the referral process. So if people are aware of their fall risk, then they could be informed of opportunities to reduce fall risk. And there's also this really tight coupling between fall risk, frailty, and arthritis. And so we'll be using that as one avenue to promote referrals into the hub and training other organizations in fall risk. So if you're interested in learning more about that, I could either forward on my presentation from that symposium, or we can explain that, just email us. And the last part that I think Trina is going to talk about is also finalizing our onboarding process for training and support through the hub. So we will have a whole system in place by which organizations can opt into the hub support and resources and training, and then that in turn helps us track what's going on. So I'll let you, Trina, maybe cover that next. But
yeah, I think it's somewhere in this presentation. But what I wanted to mention though is, as part of I've been part of the Iowa Falls Prevention Coalition since 2012. I think co-chair now for 5 or 6 years, and it's been a huge priority of ours to increase the amount of falls prevention screening across the state. So when we were kind of putting this grant in particular together, we wanted to make sure that we embedded some of our strategic action plan items into this grant application. And so we're really excited that we've really been able to combine those things. And through this grant, we'll see a lot of these action items, really come to fruition and really be actionable and hopefully achieve some of those goals that we have. So excited about that piece.
Yep.
Any questions? Because I think we have data safety and monitoring board next. So any questions at all about those two specific grant projects that we have? They're statewide. And I should also mention that many of you are on some of these teams. So we appreciate your engagement, appreciate your help, your expertise in these areas. And so, again, applause to you all for taking action and helping with this work.
Mm-hmm.
Any discussion points from the group? Quiet crowd this morning. All right. Well, one of the last things that kind of connects with these grants anyway. Greg, you had mentioned to us, and it was something that has come up with CDC and some other grants, I think the NIH potentially at one
Yeah,
point, is the importance of this data safety and monitoring board. I don't know if you want to share from your perspective, but you came to us to say, let's formulate this board.
Yep, it's required in anyone running a clinical trial, and so it's a great service and support network that'll enable the hub to attract other research projects and to track things in a safe and efficacious way. So a DSMB is helps ensure that programs are being delivered and they're safe, and that there's a procedure in place to address those issues. And so it's also required in our CDC grant. So I appreciate the hub and Trina taking the step to set this up.
Yeah, so we actually had our first meeting with the group, and you can see the members here that have come together. And again, if there's anybody else that's interested, we'd be more than happy to get you involved. Dr. Paul Mulhausen, Dr. Barry Ingebretson, Liz Fridley, and Angela Shanahan. Thank you guys for stepping up. And we had our first meeting. We created a charter for the DSMB, and we've also created conflicts of interest and confidentiality forms that we're now just kind of getting those signed. But yeah, really we're able to agree on the importance and significance of this board in establishing, safety of our research participants, but just in all of our work to bring our research professionals with community leaders in really being able to potentially bring new grant funding to the state, and for those that are working on grants, how can the hub be a support system to those projects? So any questions at all about the Data Safety and Monitoring Board, or from any of the members that are on the board?
So quick question for new potential grants, and I'm just starting the process of how we're gonna set up an intervention. So I need to first get my surgeon on board. How would the DSMB be involved if we wanted them to be involved as early as designing that project, so that we make sure, using the hub is something, how Kathy and you work well together. I know they're not here today because they are at the Johnson County Healthy Aging Fair. Now I figured out why they were not here. But so how do you guys get involved in those studies? How do you work?
So first of all, Colette, do you mind introducing yourself to the group?
Sorry. Yeah, Greg know me, but I haven't been here very often because Kathy Lee and Bailey Rickels now are our injury prevention coordinator at University of Iowa. I'm the associate research scientist for the trauma center. And so I work hand in hand with them on the injury prevention side, but I also develop research project with trauma surgeon in collaboration with the Injury Prevention Center as well at University of Iowa, and some others that we're at the point where we have worked a lot on frailty, and we do think that there may be things we can start working on in terms of developing grants now that we have the publication to support those. So I'm just interested, and I have an idea. I need to mature this idea, make it to the point where, like Craig did, we're at the stage where we can really get there and write that grant. And I feel like the hub would be a great place to and your model. And thanks, Greg, for sharing what you have done, because that's kind of the idea I had. And so I'd like to see how the hub and the Data Safety Monitoring Board could be a plus to any grant we would write.
Yeah, and Colette, I know Colette as well. We've been working a little bit with some ACL grants, trying to work on some ACL grants, but she's been really great in trying to see how we can align the hub with her work at times. So really, this is a little bit new for us, Colette. So we are also kind of learning a little bit as we go. But the way I think we've been envisioning is, if number one, there's two ways to get involved. We have an implementation and translational research subcommittee
Okay.
that I believe that, and I think Becky Buckland is on this call. If I think I saw her come in. So we would invite to some of those, invite you or your team or others to kind of, join that subcommittee. That's where a lot of ideas are developed, partnerships, collaborations, kind of discussions come in. But I see the DSMB as, if there is a project then that you think would be a good fit, or you think you'd love support from the hub to really maybe provide some support and strength to it, we have talked about having grant projects come and present to the DSMB, and then we can go through it and go through it from there. But I know that this is a little bit new for us as we learn too how to work with entities and support you all in that grant work. But Colette, as you know, that I definitely try. We always try to work to find ways to work with you and to make these grant projects work. So yeah.
No, it's great because, like Craig said, my goal would be to go with the NIA for an NIA grant. And if we do an intervention, it's going to be a clinical trial. So we need a DSMB. This is now a requirement. We don't have a choice. And so knowing that you're building this as part of the hub is huge. And so, if there's any way I can help, I'd be happy. And when I'm really at the point where I feel like I'm comfortable sharing what the idea is and how we can frame it, then I will definitely contact you and be in touch. And we are looking at that fall prevention ACL grant again. Let's see how it comes out. I haven't seen it out yet, so I'm looking regularly on the ACL grant, and I don't know if they're going to renew it this year, but if we can, we'll definitely try to go on again with both stepping on and Tai Chi for arthritis. So, and using you, as you know.
So Colette, just a quick thought, and again, Trina can mention, like, we can get you hooked into the translational research subcommittee where we talk more about research and implementation. But as I think, Trina, the other operational goal would be anyone that does want to make a request to the DSMB that would then either make that directly to you, or there'd be a button on the website. So somebody could say, I'm interested in submitting a study through the DSMB. And then it's up to the investigator to frame what their needs are, but then, and that goes into the grant, but then the DSMB policies would be already set up at the hub level. So then you would know, like, how often they meet, what their procedures are, that kind of.
No, that would be great. I mean, this is a great plus, honestly. I think that's gonna really help. But Greg, yes, if you don't mind adding me to that translational.
Yeah, sure.
I'll do my best. Not that I can always, right now we're short staffed, so I'm doing the work of my study coordinator and my job. So it gets a little busy, but it's anything that I'd be happy to participate and help Bailey also. I know Kathy has retired, but she's still helping Bailey a lot, and I know that little by little we'll work together with Bailey a little more and move forward in this direction. And we definitely want to keep this partnership and working with you guys. So
perfect.
A great forum to discuss our injury prevention efforts. So
excellent to hear that, Colette. Do reach out to me, Greg. I will work on putting something on the website about the DSMB, and then a button that people then can directly get a hold of me, and then we'll continue to develop those resources and those ways to get connected. And I see Paul has a question. So Paul, go ahead, or a statement.
Yeah, I'm more of a editorialist than I am a question asker. So yeah, so I guess what as a member of this board, a charter member of the board, we're new to this, so that's the first thing to recognize. But we also, in our charter meeting, had a deep discussion about administrative compliance and setting up our charter and our board with attention to the future. So I think Trina and Greg have been very wise to view this as something that could be used in the future. And in our initial charter meeting, we talked about how to make sure we set this up well from the get-go, so that I was thinking in terms of Greg's work. So as Greg's work expands, we're a high value resource to that team. But I also think if we do it correctly from the start, we could be an asset to others who want to work with the hub and use its services as part of their translational or even primary investigation work. I did have one thought though, and my goal, and I know I'm just an advisor here, my goal for this was to work out as a long-term sustainable business model. And I don't mean the data safety monitoring hub, I meant the Iowa Community Hub.
Right.
These kinds of early efforts at, using the hub in translation research and, grant work, you got to get started. But I think one of the things that we also need to be doing is looking beyond the grant funding. Ways to try to get this to capture the resources that flow through clinical care. And so that's just something to keep in the back of the mind as we work through both the translational issues, which I think are important to proving the hub as a resource, but also not to get lost. Maybe the goal is changing and evolving. I don't know that the hub in its original vision was as a tool for investigators, but I do agree that it can be a valuable tool as long as we keep moving it towards something that I think is sustainable, as a community hub.
Yeah. Yep. Paul, just to build on your point really quickly, like that, I totally agree that it's needed also to ensure safety in programming of CBOs delivering these programs, so it could have best practices for how these programs are done. And then the CBOs can also have confidence that they have some level of support and oversight for their work too. So like a different kind of consent form that's used, so the board is useful for that as well.
I'm happy. Thank you, Paul, for always sharing your editorial. Is always good to hear. And it is important that, we start looking at the blending and braiding of funding for, not only to get out to our community-based organizations for their sustainability of these programs and these projects, but also, we have to start thinking about for our sustainability as a community care hub for the state to help continue this work for everybody too. So good point all across, and excited that you guys are excited about this work. All right. Greg, it's about.
Yeah, I can be really quick. Yep.
But this is important too. So very good.
So in addition to the grants we're doing, there's also just another really relevant opportunity, pilot interventions to integrate social care and medical care to improve health equity. I mean, the title says it all right there, but now click to the next slide, Trina. So this is an NIH opportunity, and the reason I wanted to share it is we're interested in pursuing this additional grant because it's leading to exactly what the hub's doing. And actually, I'm at a conference right now, and they're talking that NIH is now looking for ways to fund entities like hubs, independent of whether a research team is involved or not. That's one of those Compass grants I told you about, or we looked at, Trina. But this particular opportunity, if you just read the text there, supports pilot and feasibility trials to test interventions that involve screening for and addressing social determinants of health. So then it says patients' endorsed social needs could be addressed by appropriately navigating patients to resources that address those needs. So we're really well positioned to do this through the hub with some of the elements we've built. So we're interested in exploring this. And so it's I shared it mainly as an example of how important the hub is to this type of work, and that NIH cares about the very work that we're doing. So I think I might have one more slide. Yeah, these are the preliminary concepts for specific aims that we would like to evaluate enhanced social determinant of health screening through a community care hub. And this, if Heather, if you're still on, that this gets at exactly what we're trying to do is offset the burden on the healthcare system and have more of that screening happen at the hub level. Then we're going to evaluate the integration of equity training within our motivational interviewing course that we have here on campus. And so that links to the diversity and equity group, our ideas that we're exploring. And then we'll be trying to build a pilot study for evaluating how we can use the social or address the social needs through the DPP program. And that'll involve like possibly addressing food insecurity issues with one of the initiatives that Trina's already been building on the food is medicine effort. So that's all, I think all I had there.
This is great. Again, it's just an introduction. We're still kind of putting our thoughts together and working on the content, but we're excited for this opportunity. But number 3, again, I think Allie is on here from NACD. We have worked with her for a number of years now with our DPP work across the state, Iowa HHS, with, complementing and supporting the work that they do through DPP. And one of those things that and I'll go pretty quickly because I'm going to keep an eye on the time here because I do want to make sure that we get to our new hub DEI advisory task force that we're looking at. But one of the things that we have learned about from other states, from our national partners, and then even in Iowa, there's a great need, is the idea of coupling or bringing together food with our evidence-based programs. So we know that evidence-based programs are effective. They have proven results, but the issue is getting more people screened and determine eligibility for those programs. There's a lot that goes into connecting the referrals to those programs. And not only if we get a referral, there's a lot of work that goes into the enrollment process. We got to address social determinants of health, because just because someone's referred doesn't mean they can make it or agree to a program because maybe they don't have transportation or they have childcare issues. And for some, they can't even address regular food on the table. How can they even think about participating in a program like DPP? So what we're trying to do is couple these efforts together to, number 1, increase the healthy food consumption, increase the referrals from providers, because we're saying, hey, not only will they fight whatever this chronic disease program is, or fight the chronic disease in this program, but you can also feed your patients through this effort. And then finally, one of the more important ones is if we can retain participants in these programs, they will then be able to experience, feel, and transform into these proven results that these programs have. So we're working with Capital City Fruit, and we are looking at, especially with DPP and other programs, for the time that someone is a participant in a program and have determined that they have food insecurity or have needs for food, we want to provide monthly food boxes delivered to the homes of those participants on a monthly basis, as long as they're a participant in the program. So that's all say there, and that's what we're trying to bring into this program, this NIH grant as well. Joy, we have just a few minutes. Do you want to just share a little bit about this next one?
Sure. So, obviously core to community care hubs is, health equity. And so we've been meeting also through the ACL, and one of the strong recommendations they have, which we want to implement, is a DEI advisory task force. This is really leveraging diverse community voices to make sure that we're making the investments that the community wants and meeting the social needs, exactly as Trina just talked about. Food is medicine. How do we know that's really helpful, and what approaches and how should we implement it? A lot like the human-centered design and the arthritis. So we're kicking off this board. It's going to start in October. Have already recruited individuals, and we'll be doing the same as the data one. We'll be creating a charter. We envision this group really to be giving us the lived experience perspective and helping us hold accountable to the pieces of health equity. So anything else, Trina, you want me to add there? Or?
No, I think that that was good. We didn't have, a lot of time to share that out, but just to know that this is an effort that we are starting. We're excited about it. And we're excited about the people that have stepped up to want to join that effort with us. So thank you, Joy. Just before we leave here, any questions, any discussion points, any thoughts from this group? I know a lot of times, you know, we're sharing out a lot of information, and always mean to have a discussion time at the end, and it seems like we rushed through that. But anybody have anything now, please bring that up to us. Just come off mute. All right. With not hearing anything, I will share out the meeting summary, so you'll have some of that information that we're shared today. Just again, a thank you to Heather for presenting today. It's great information. And also the recording will be sent out too. So thank you so much, everybody. Have a great weekend, and hopefully we'll continue to do great work with you all.
Yeah. Bye all.
Bye.